You look here, look there, whatever you want to do. Do a little bit of both.
Okay.
Yeah. I don't know how they do it in Greece.
I don't think they do it. I've never done a podcast in Greece.
Podcast doesn't? Greece doesn't have podcasts?
I bet they do. I just haven't done one.
How long has it been since you lived there?
I've been in the U.S. since 2012.
Couple of years?
14 years.
14 years. Yeah.
But I tend to go back.
How's
at
it?
least a couple of times a year.
Does USA have any culture at all compared to Greece?
Amazing culture.
Yeah.
Yeah. Amazing culture of getting things done.
Is that right?
Yeah, I love that.
Oh, so just the busy society. Just produce.
Yeah, not only that, but process is respected. You know, you go to Southern Europe and the weather's beautiful, food's amazing, people are heart connected, and sometimes process is like secondary to flow.
Yeah.
Yeah, here we have a process and we kind of stick to it, which is also beautiful.
Yeah, that sounds so poetic. I've been to the Mediterranean coast in a few countries, at least several countries, and I miss that. I like that. Just there's no hurry, right?
Yeah.
Just we'll get it done eventually. But right now there's the beach. Right now there's this beautiful weather, right?
Exactly. I think the secret sauce is to kind of strike a balance and get things done. And I think it's very different when you have to do creative things, like poetry you mentioned, right? Or create art, versus when you want to help people with their oral health and their function.
Yeah, we should kick it off right there. That's what we're here for. Welcome back to the All In, All On X podcast, where we take you behind the scenes of full arch dentistry, innovation, and the people who are redefining what's possible. Here we go beyond the procedures and into the lives of people shaping full arch dentistry. This isn't just about implants or workflows. It's about the lives we build, the decisions we make under pressure, and the leaders who push this profession forward when no one's watching. Get your head straight, because we're about to go all in. The All In, All On X pod is brought to you by JB Dental Labs, the elite lab trusted by full arch surgeons, prosthodontists, and digital forward practices internationally. JB specializes in precision full arch restorations, zirconia, PMMA, photogrammetry workflows, and fast turnaround times that don't sacrifice quality. JB delivers a truly digital workflow powered by their proprietary online portal for easy case uploads, real-time tracking, and fast, streamlined communication. If you're looking for a lab that understands immediate load, passive fit, and the demands of modern all-on-X dentistry, learn more at jbdentallab.com. Tell them that the All-In, All-on-X pod sent you. All right, welcome back. I'm Adam Hogan, your host of the All-In, All-on-X pod. I'm talking here with Dr. Giorgio, and I'm going to mess this up, Dr. Giorgio K. Kotsakis.
Yes.
I'm trying, man. Dr. Giorgio Kotsakis. So this guy, I mean, I've got a resume here. It's just legendary. It prints on like 9 sheets of paper. PhD, board certified periodontist, clinician scholar, DDS from, I'm going to mess this up, Kapodistrian University?
That's the big name of it. It's the University of Athens.
Say that one more time.
National and Kapodistrian University of Athens, Greece.
Kapodistrian University of Athens. I love it. Practice dentistry in Athens. And folks, we are not talking about Athens, Georgia. Athens, Greece, prior to moving to the United States. Residency, periodontics masters in Minnesota. Oh my gosh, this just goes on and on. You've been to Seattle, Washington. You're associate professor at UT Health San Antonio. I mean, you've got numerous awards and accolades all written down here. I'm not, this resume is literally like 3 pages long, but now fast forward, running the literature research department at Rutgers Perio. Is that correct?
Yeah, I'm the director of research and the assistant dean for clinical research at Rutgers School of Dental Medicine. We're in Newark, New Jersey.
That's fantastic. And specializing in peri-implantitis treatments. Is that correct?
I have.
Yeah.
I'm a board certified periodontist, so this is what I love to do. But for nearly the past decade, I've been honing into peri-implantitis. It's kind of a beast of its own.
Yeah.
And I've been very excited, fascinated to untangle how things work and how we can fix them.
For those of you who, if he wasn't close enough to the microphone, he said a beast of its own, not what I thought I heard to begin with, which was the BITCH of its own.
Beast,
but it could be a BITCH of its own. Yeah. Maybe. But it is a beast. I mean, let's talk about it. How many implants are placed in the world right now? Do we know, or in the United States?
So estimates are that more than 10 million titanium implants go into patients' mouth on an annual basis. And we know that the incidence of peri-implantitis is approximately 10%, prevalence being between 10 to 10%. So roughly 1 million implants globally per year are diagnosed with peri-implantitis. And what's high impact is how that translates into healthcare costs, because you should imagine, right? There's no insurance coverage right now for it.
Right.
Most of it is patient own finances for healthcare expenses. This figure has exceeded $1 billion globally, and it's tracking to between 2 to 5 billion by 2035. Peri-implantitis only.
$1 billion globally to treat peri-implantitis. That is a huge number to comprehend.
Yep.
You know, how many people that must affect? Hundreds and hundreds of millions of people, right? I mean, you think about it, and we're sitting here in the back of an all-on-4 practice, all-on-6, all-on-X, whatever. You know, we place 20 implants a day. You know, it's to think about the percentages of how many of those might need peri-implantitis. I think we should talk about that. We should kick off talking about how to prevent it. How do we prevent that $1 billion number from being an actual number? How do we cut that in half?
That's the question we need to be asking. So I'm coming 2 weeks, I think, after a meeting we had in Chicago with the American Academy of Perio, peri-implantitis best evidence consensus, focusing primarily on prevention and maintenance. So we talked a lot about primordial prevention, primary prevention, and then, of course, tertiary prevention. So I think a lot of it has to do with what to do, but even more so might have to do with what not to do.
Knowing your exclusion criteria, you're saying, for patients, or your exclusion scenarios, when do you not treat with titanium? Is that what you mean?
I feel like there's a component to when not to treat, and that those contraindications are shrinking and shrinking and shrinking as better implant surfaces are being developed. There's a lot that comes into play with modifiable risk factors. A very common one would be patient has severe active periodontitis throughout in their mandible, and they're missing all their teeth in the maxilla. Do you treat right on the spot, or is there something you need to do before that? And other ones have to do with maintenance, have to do with what component of that peri-implantitis might be iatrogenic, right, on multiple levels, restorative level.
Right.
Are there any guidelines on what to do? If I have excess cement, what are the chances I'm going to have peri-implantitis? These are key questions to ask. But then again, when the patient trusts us with saying, you need to come back for maintenance, I need to see you every 4 months, 6 months, 12 months, whatever the individualized regime is. And then when they come for maintenance in the dental office, we applied something that can actually damage the titanium surface. Are we accelerating the problem? Are we helping the onset of the problem? These are key questions that we're negotiating right now. And finally, we have some really cool answers regarding those.
So when you talk about treating peri-implantitis and treating the implant surface, you mentioned, are the things we're doing making the problem worse? Are you talking about mechanical debridement? Are you talking about diamond burrs and things like that, and scaling implants? Is that, you want to elaborate on that?
Absolutely. I think this is a big part of the problem. Since 2017 or so, there's been amazing studies in the literature, including some of those that we did when I was at the University of Washington with Diane Dobert and Luciana Safioti and a lot of other folks. And what we found is that in peri-implantitis, we not only have this bacterial problem that we know from periodontitis, you have these gram-negative bacteria that start to thrive, they cause inflammation. We have that. That's the foundation. But on top of that now, you start adding biomaterial breakdown, because the implant surface, once you have peri-implantitis onset, is not the biocompatible implant surface you got out of the box and placed into a patient's mouth that's perfectly done by the company with whatever acid etching process or other modification they do. Now that surface has lost its biocompatibility. And not only that, if we try too hard in an abrasive fashion to remove the biofilm, think titanium curettes, think metal ultrasonic tips, think diamond burrs that you mentioned, then we start releasing massive amounts of titanium particles. And I'm sure a lot of your audience have heard about those.
Right.
Just to put it into perspective, there's a classic study from the University of Tel Aviv by Michal Eger and Yangel Gabet, where they use ultrasonics outside of the mouth around implants, and within a minute, depending on the implant surface, by cleaning it, right, by hygiene with an ultrasonic metal insert, you release 1.5 to 3.5 million titanium particles in the peri-implant microenvironment. And what's really key in this study is that when you take those particles and you implant it in the skull of a mouse, do you know what happens? Do you have any perspective?
I can take a couple of wild guesses.
Please go ahead. Please go ahead.
Dementia, derangement, confusion.
Well, they didn't look into that. They didn't look at long term. But what they looked at is with a micro CT, they had osteoclastic resorption pits. So you inject these particles, titanium microparticles that are under 10 microns, that came out from the mouse. You put them back in the skull where it's a good bone model, and you see that there's inflammatory bone loss directly from the particles, even in the absence of bacteria. So imagine what's going to happen if I come to you to maintain my implant. You start cleaning it, right? And then I have titanium-related inflammation. And how do you treat that?
It's all very scary. Because when I came into this practice, little history, by the way, I was coming out of the Navy. I was looking at perio residencies. But there was a gentleman practicing here, Truman D. Baxter Jr., and he had been placing implants since he learned from Hilt Tatum in 68, 72. He'd been placing implants here for 30, 40 years. And back then, treating peri-implantitis was basically, we're just going to throw the kitchen sink at it. We don't know what works. So it was, let's flap it, let's put a burr on it, let's abrade it, let's clean it off with a burr, let's drop some recycling slurry in there, maybe some citric acid, maybe a bit of grape jelly and some honey, because that's good for everything. And then, let's hope for the best. And, with what you're telling me now, and it's, I've been reading this in literature and hearing about this the last couple of years, but with what we know now, it's no surprise that it almost never worked. It really almost never worked, So I became of the mindset, if we get peri-implantitis, we're just counting the days until we take it out.
Right.
So, but you have opened my eyes talking to you the last few months over our chat, over text. There are some things you can do. You showed me an x-ray today, more than 50% bone loss on an implant that is supporting a bar, supporting an all-NX hybrid. And the first thing I thought of was remove it. And you tell me there's hope for that implant. What are you going to do for that implant?
Yeah, the reason, and it really matters because the case I showed you, I think there were probably four implants in the maxilla supporting a hybrid zirconia frame. So what is the most predictable treatment when we have an implant with 50% bone loss like the one we saw? Absolutely. Beyond any reasonable doubt, the most predictable thing to do is remove that implant, graft the area, start over again. The cost incurred to the patient, right? And the time to get that new hybrid and what's going to happen in transition. These are all patient-related components having to do not only with their satisfaction, but primarily with oral health-related quality of life, right? Aesthetics, function, work life, everything. So the capacity to give 5 or 10 more years of that function to that implant is tremendous in terms of impact to the patient. So where the literature stands right now, if you look at the most recent systematic review we have on the topic in 2024, looking at success of peri-implant surgical treatment, because we know it has to be surgical for it to work. Non-surgical doesn't really work. The success rate, disease resolution rates, as we call them, are under 50%. So that makes it by far and most the least predictable regenerative procedure we do in implant dentistry across the board. So we got together with my team, maybe this started, I think, 4 to 5 years ago when I was still at UT Health San Antonio in Texas. And we started putting a clinical trial together because the data was pointing to one very determining factor to why we're under that 50%. And what we did in the study was very simple. We got implants with peri-implantitis. Bone grafting was the same between the two groups. We used biomaterials from a company that supported us very nicely. Great membranes, great grafting. But one implant was treated with titanium curettes, which is the most common thing that people do for implant surface detoxification. The other one was cleaned with a rotating nylon brush, very similar to the brushes we use for individual hygiene, just rotating and adapting. So we're comparing head-to-head, abrasive to non-abrasive.
Right.
Same operators, same biomaterials, same surgical technique, flaps, everything. But the difference is in the intervention for cleaning the implant, right? At the end of the day, and this last segment of our publication is coming up in the Journal of Periodontology in the next quarter, showed that in implants that were treated with titanium curettes for cleaning, we got a disease resolution rate, I think, approximately 20%, right? Extremely low. 80% of the cases failed to treat.
Yeah, that's worrisome.
Some of them failed catastrophically.
Right.
So in the months after our treatment with the abrasive approach of cleaning the implant, extreme downhill, you had like 20, 30, 40% more bone loss. And implant exfoliated. It was crazy. The non-abrasive group, when we looked at cases of up to 50% bone loss, no more than that, we had up to 75% disease resolution rate. Now get the 20 and the 75, average them, you fall a little bit under 50%. You see that aggregate systematic review. But systematic reviews, they always tell you, well, we need more data. We need more info. It's like an average, but none of us is an average person, right? Everybody's unique.
Yeah.
So when you look at, is there any determining factor that can take me from 20 to 75%? Yeah. Don't abrade that implant surface. Don't ruin that implant surface.
I think we have to say that again because I think the entire audience right now is already thinking about their rotary instrument. I mean, we're dentists, so it's like so easy to pick up a handpiece. It's got to be the catch-all cure for everything under the sun, the handpiece, the handpiece, the handpiece. But you're saying just nylon brushes, just nylon brushes alone will far exceed the handpiece. So listen to that. Put down the handpiece. Question, do you ever pick up a laser? Are they good for anything with peri-implantitis anymore?
So when we're looking into lasers, we have the kind of the hard tissue and soft tissue lasers. The most researched one for peri-implantitis is erbium YAG wavelengths. And when you have the YAG, you can clean the implant surface with it. You're not going to abrade it depending on the settings. You're going to remove some biofilm. There's not a lot of mineralized deposits. That's the key thing in peri-implantitis. We just don't find calculus. You got to remove biofilm. So at the end of the day, if you use an erbium YAG or if you use gauzes soaked in saline and you shoe shine or burnish the implant surface, it's pretty much identical results in the literature, which is very, very interesting, right?
So the laser's unnecessary.
The lasers are not superior with present settings, with present protocols to simply shoe shining. But if you're going to use a titanium brush, laser is way better than this.
For sure. Okay, I get that.
Yeah.
All right.
Yeah.
So, I bought an YAG laser over 10 or 12 years ago only for peri-implantitis because back then, like I was saying, we were throwing a slurry, literally sometimes a slurry, just anything under the sun, try to treat the peri-implantitis. I bought a practice that had a lot of implants that are 10, 20, even 30 years old, and I needed something to treat peri-implantitis. Now, I didn't run any scientific study on it, but I am pretty certain that my results were far better than anything I'd done previously speaking. You heard me describe to my associate earlier. I take cold steel and I would cut out all the granulation tissue just to get there faster, cut out all the scar tissue, debride it. Then I would detoxify the surface with a radial firing tip. And just that alone, I was seeing far superior results to anything I'd done previously.
Yeah.
But you're telling me I could have just taken out a shoe shine kit and just polished it with cotton?
Exactly. That's what I'm telling you, which is crazy.
That was a $65,000 mistake, I think. 75 maybe.
Well, if you have it, it's great. But I think what happened when you bought it is you made an amazing investment because at the time people wouldn't even think of using the shoe shine. I mean, you're throwing the kitchen sink at it and it doesn't work. Who's gonna be crazy enough to go back and just use a shoe shine with gauzes or cotton pellets with saline?
Yeah, you would have thought I was a quack. Crazy.
But what you did was absolutely right because you went with a non-abrasive approach. Now, is it the most cost-effective? No. But for folks who have the erbium YAG, it's safe. You can use it on the implant surface. You can detoxify. There's no superiority.
Yeah.
Okay. But using something non-abrasive is so much better than any quasi-implant specific instruments like titanium curettes or titanium brush or anything of that sort that has come out. What's very interesting is we got together in 2023. We were in Bogota, Colombia, right after COVID, did the first IADR meeting. IADR is the International Association for Dental Research, the largest organization for dental research. We held the best evidence consensus in Bogota in person for the first time after the COVID. And we talked about peri-implantitis, and we got some experts run systematic reviews in terms of regeneration and what can affect it. And one of the key conclusions in the consensus paper that was published last year in the Journal of Periodontology is that if you use a titanium brush, you reduce the regeneration you would get had you not used it, which is remarkable because as clinicians, right, we put our best effort, we invest in anything new that comes out to give our patients a better deal, right, a better outcome.
Right.
And then at the end of the day, in peri-implantitis, it's the one thing in implant dentistry that if you do more, chances are you're going to make a mistake.
Right. Yeah. I can appreciate that for
Exactly.
sure. I've made a couple of mistakes along the way, but that's what makes you an expert. I think it was a Danish physicist who said that an expert is somebody who has made all of the mistakes possible in a very narrow field.
Exactly.
Yeah, I exemplify that.
Exactly.
Perfectly. All right. So I'm going to not invest in laser tips anymore. Anybody out there want to buy a laser? It's still working. I mean, I said 10 or 12 years, but I just realized it's 26. I was thinking 23 in my mind. But yeah, we've had that laser for a long time. Very good quality piece of machinery. Only one breakdown. Only had to have it reserviced one time all those years. So you've detoxified. You took out the granulation tissue and you took out a high-tech piece of cotton and you buffed the implant clean. It's 2026, people. Like, this is ridiculous. 2026. And you buffed it clean with cotton. How do you get the regenerative growth? What do we do now?
Well, I'll emphasize on that. Absolutely. We have to do things that, in that regard. Let me set the foundation for this, right?
Okay.
Why a guy who's invested 10 years of his career researching peri-implantitis tells you got to get a gauze, soak it in saline, and buff the implant surface. Well, because I want people to realize that what we're trying to do when we're detoxifying the implant surface is remove biofilm. Remove biofilm is what you and I have right now in our teeth after the very nice lunch we had, right? Mm-hmm. It's that sticky surface that can go away by brushing our teeth. Mm-hmm. And of course, if you don't have calculus, none of us wants to get an ultrasonic home. I mean, we're dentists. All of us can get an ultrasonic tip at home, right?
Yeah.
But none of us wants to get that at home and start cleaning our teeth with an ultrasonic every day, because what's going to happen is we're going to start eating up the cementum.
Right.
Right?
Yeah.
So in the same capacity, if we don't have calculus, we don't need an ultrasonic device to clean our teeth, right?
Fair.
So when it comes to implants, their biology, their material surface chemistry is so interesting that the abutment, that titanium grade 5 component that's above the gum, that's exposed to electrolytes and saliva, that has the proclivity to get calculus. You're talking about a hybrid and all an X, especially if the zirconia is not hyperpolished, you can get a lot of calculus there.
Yeah.
But when you have peri-implantitis, if you open up those defects, you see massive sticky granulation tissue, which is the one part that we're going to talk about. And then you see an implant surface that doesn't look as good as new because it's partially corroded now, but doesn't have calculus on it. So why would we need any of those abrasive instruments that you and I talked about? What do you need the curette for?
Yeah.
Would you take a curette to clean after you eat your food?
No. You would certainly do damage to your natural teeth.
Exactly.
And you've seen people come in who have they bought these curettes at home and they clean every day, and they certainly do damage.
Yeah.
Very
an hourglass shaped.
Yeah.
Yeah.
Diligent oral hygiene, still need their teeth replaced or restored in some way.
Exactly.
Yeah. So take me down the regenerative.
So regenerative, it's very interesting that implant surfaces are extremely cytocompatible. You know, you talk about this new chemically modified surfaces, this hydrophilic surfaces we have now, and we can get immediate loading 6 weeks later. Right? Mm-hmm. So they attract bone cells, they attract growth factors very quickly, very early, very rapidly. What happens once we have biofilm on an implant surface, that starts corroding the implant surface to a certain extent. Mm-hmm. And add to that any damage that we might do with maintenance or procedures, that implant surface is just not as biocompatible anymore. Mm-hmm. So instead of having the bone cells run and migrate and attach on it, which is the nature of osseointegration, that's what happens, right? We make a void with our drill as we go in. We place an implant that has a relatively good fit in that void, and bone cells jump on the implant surface.
Right.
Well, now they don't really want to. Okay, now they're just taking it easy, engaging, like, is this safe for me? Should I go there?
Like 1 foot in the water. Is the water warm enough? No, do I want
Are
to
there any alligators?
Yeah.
I don't know.
Yeah.
Right? So we need to do something to enhance that migratory potential. That's called chemotaxis, right? Okay. Whenever you have a cell going to a surface. So we need to do something to enhance this osteostimulation. So how do we do this? We go above osteoconduction. As everyone knows, the majority of biomaterials we use in dentistry today, like FTBA, That's the majority of what people put in patients' mouths today in the U.S. That's an amazing bone graft, extremely biocompatible, but it's osteoconductive, which to the general person, this very simply means it's kind of a scaffold where the bone cells can slowly walk on it and get to where they want to be.
Yeah, I explain it to my patients like a ladder. If they ever ask, it's like climbing a ladder.
Exactly.
Right.
Yeah. Well, I live by New York City, so I call it a scaffold, but it's the same deal.
Yeah, we have smaller buildings here.
Exactly.
Yeah, same thing. Okay.
So now we actually want something that's like an elevator, something that will take the bone cells by the hand and say, go up on that implant surface. And we've shown in our studies that you need something that is either osteostimulative or osteoinductive, or it's a good idea to use a combination of locally harvested autogenous, not 100%, but locally harvested. In our studies, we use 30% autogenous bone chips and mix it with an osteoconductive scaffold.
Right. We got a fan. I thought for a second one of my staff was like, hey, can you come see a patient right now?
Right.
What's up, Evan? It's our producer. I was like, oh, you got to be kidding me. It says do not disturb. I'm always like in need. All right, so where were we? We were talking about osteoconductive and osteoblastic activity.
So you need something that's osteoinductive. What I teach people to use in our courses is either get a really good osteoconductive graft that turns over really fast, not a xenograft. This is not a case for a bovine xenograft. We're talking about a human FDBA, and then make it more osteostimulative in some way. One great example is add PRF and make sticky bone, add your autologous growth factors. Another one is a melogenin, works really well for this indication. There's a couple of studies that commercial product is Emdogain, and you can pre-mix that with your bone graft and get kind of an Emdogain sticky bone. The other way is to do 30% autogenous bone chips, locally harvested. That might be a little bit more expensive because you need a scraper, but equally effective. Or another kind of hack that I like to use is mix my FDBA with DFDBA. I like a particular product that comes in at a 70-30 ratio of 70% FDBA, which gives me my mechanical stability that I really want to have, and then adds the 30% of the demineralized that gives me my osteoinductive potential, BMP2 activation and whatnot.
That's awesome. So you're talking about just making your bone graft, giving it that +1 factor, that little Excalibur, right? And you mentioned PRF, you mentioned Emdogain, you mentioned autogenous bone, 30%, and you mentioned a mixture of 70-30 DFBA to
30% DFDBA, 70% FDBA. That's the only product I know is Encore by Osteogenics that I tend to use quite a bit.
That's some great advice for the listeners out there. So you just gave the listeners 4 great modalities for gaining regenerative potential after you buff and shoe shine your implant with your cotton and you leave your laser in the corner.
Well, I mean, if you have the no, don't get me wrong. If you have the laser, use it, right? Because it's not abrasive and will remove. But essentially, the incremental benefit doesn't really justify just getting a laser only for that in the present moment. And a lot of it has to do with the fact that people haven't done clinical trials to optimize the parameters, right? And you know, as you know, you can play with the parameters quite a bit.
I feel a little bit exonerated, a little bit because with our bone graft, we've been adding PRF to our bone graft. I've been doing that since 2006. We had the harvest unit. It cost us $800 or something to get PRF for somebody. We didn't even have PRF then; it was just PRP, and it was like this $600, $800 procedure. And now it's like we got it all in the, little $1,000 centrifuge from Salvin, and it's $6, and we put it on everything. Right. So we've been putting that in our bone graft for a long time. Yeah. So, I believe it though. Can you believe there are still people out there who say PRF doesn't work, or do you? Would you agree with that? I mean, you just mentioned putting in a bone graft, so obviously not.
I think, Rick Myron especially is a guy that has done a tremendous amount of work on that. And I've done a little bit of work in the early days. And we know very well that PRF works for everything soft tissue related. Yeah. Absolutely outstanding. Right. And for bone, I think where people get confused is that PRF will not give you more bone. Right. Okay, so because when we're talking about, let's say, D2, D3 bone, you look at a CBCT, what's the percent of mineralized bone fraction you have in an image? About 60%. Okay. Right? If you have 100% bone, you get osteopetrosis, like it's not a healthy condition, right? You need marrow spaces, you need empty spaces. So if I have a socket and I put FDBA with or without PRF, a year later, they're absolutely identical. The quality of bone is pretty much the same. What happens, though, is one of them is going to have mineralized bone with good stability for your implant placement, 2.5 months later, the other one 4 months later.
Right.
So it's an accelerator.
Right.
Right.
Yeah, I'm well aware of the studies that say that PRF doesn't really help bone maturation or formation, except to say that secondarily, I believe it does, right? I mean, if you get better soft tissue healing, better regeneration on the surface, you're going to have better underlying maturation underneath. Maybe they both arrive at the finish line eventually. Is that, I think that's what you're saying, right?
Right.
Yeah. Hey, if today's conversation is pushing you to think differently about full arch dentistry, that's exactly why we built the Atlantic Implant Institute. This isn't just a weekend course or a set of disconnected modules. The core continuum is a purpose-built curriculum. It's designed to develop full arch surgeons and prosthodontists, not just expose you to a little content. From boot camp fundamentals to advanced prosthetics and digital workflow to remote anchorage and FP1 philosophy as well, we teach you structure, judgment, predictability, didactic, hands-on, type it out, live patient cadavers. Plus, we teach business thinking required to make it all work in real practice. There's nothing like it anywhere in the country because this was not built to be common. Learn more at theatlanticImplantInstitute.com. So we're definitely in agreement with that. I want to go. So have we beat up peri-implantitis pretty well? Is there anything else you want to add on that?
I think we're good. I think the key take-home message is that in peri-implantitis, we don't want to ruin the implant surface. The way we're talking about it in our consensus statement from the Academy is remove biofilm while maintaining titanium surface integrity. So anything abrasive, we now know is a no-go because it can actually make things worse.
Right.
And there's a lot of things we can do for bacteria. There's nothing we can do about titanium particles in the tissue, except, as you said, do our best job to remove that granulation tissue that's fully infiltrated with these particles.
And that paper, that position paper, will be out, published about when?
It's going to be published by the end of the year, but there's already kind of a prequel to that from another consensus meeting last year. We have consensus meetings on peri-implantitis every year, seems like. So the AAP-AO consensus statement from last year is published again in the Journal of Periodontology and available for people. Okay.
I'll have to remember to look that up. I put it into my maintenance lecture in module 1 of, core bootcamp fundamentals on All on 4. We talk about maintenance of these systems and how to take care of them. So I'm going to have to look that up and put it in there for this next August.
And I will tell you what's really exciting, and I got to let the audience know too, is that we're playing with some new toys for peri-implantitis that are not fully launched in the market, but will be. So the good news is that industry is listening to these consensus statements, listening to the updates, and there's actual non-abrasive implant-specific instruments that are coming out. The number one that I'm particularly excited about is a water jet that will be able to remove biofilm without even touching the implant surface, air-free, minimizing risk for emphysema. The other one is that I think the rotating nylon brushes that we use in our study will become commercially available too. So we'll have more tools that will help us get a little bit better than the shoe shine. With the gauze and the saline, which is the staple. You got to keep that in.
Right. Yeah. Nothing like a good shoe shine. But one of these, you've had a part in developing one, I believe. We talked about at lunch. Which one is that? Where can we find more information on that?
We did in my lab, we did some of the foundational studies for developing the water jet technology, which was kind of a fluke because I love giving water pick to my patients. So when we were doing some very early studies with some of my master students in Washington, I asked water pick to help us figure out if we can really remove biofilm using a water pick from implants, because people say, well, you don't touch the implant surface, right? Are you going to remove anything? And we saw that it knocked things out of the park like nothing else. So from that point on, we started looking into developing a technology like that for the dentist. And finally, our studies were looked at, and there's a startup company that picked up on them. Created a device called the Bacterator that's going to be launched pretty soon, I hope. And we did some amazing animal studies, even a ligature-induced peri-implantitis study where you can really see histologically is there re-osseointegration, reattachment of the bone. And we were able to get reattachment of the bone with just saline, no chemicals, no medicaments, both on zirconia and titanium implants. And zirconia is a whole nother discussion, but very exciting stuff.
Imagine that, just saline. You didn't even have to put like doxycycline slurry, tetracycline slurry, chlorhexidine. God, should we talk about chlorhexidine anymore? Does anybody talk about chlorhexidine?
You would be amazed at how many people talk about chlorhexidine. And that was my master's thesis when I got my master's in Minnesota, to show that chlorhexidine is cytotoxic.
Yeah.
To show that if you touch if you touch an implant with chlorhexidine, you don't allow the bone cells to reattach to it, you compromise regeneration. Ultimately, we did another of those animal studies back there, and we found that chlorhexidine halves the regenerative potential of the case if it touches the implant surface.
So it's, I've done a couple of things right in my career, maybe two, three. But when I came in here, every implant doctor that had been trained in the 70s and 80s when you got and I'm going to say just about every, because I've talked to all the old timers, back in the academy, back in the early 2000s, and anybody trained in the 70s or 80s, when they gave someone an implant, they basically gave them a chlorhexidine prescription for life. I mean, that was very common. I mean, saying everybody, it seemed like 95% of doctors were like, I had patients in here that were like, can you renew my chlorhexidine prescription? For a couple of years, I'm like, why are we doing this stuff? I know about the cytotoxicity of this. We know that it doesn't really disinfect anything until like a 12-minute contact time anyway. So having somebody go in the restroom and rinse with chlorhexidine for 10 seconds before they get their implant is absurd. But yet everybody was doing it. And first, it took me 5 years to get my patients convinced they don't need chlorhexidine.
Wow.
Yeah, forever. I mean, I literally had to put my foot down after a period of a few years and say, I'm just not doing it. It's just, it's nonsense. And to think that all these people were washing their mouth with chlorhexidine for decades. Really. I mean, I don't know if you're aware of the history in the United States, but I mean, for decades they were doing that.
Wow.
Just bottle of chlorhexidine on their kitchen, on their bathroom sink.
Just a little fun fact about this. It's so interesting, but there's newer studies showing that all these patients might have gotten hypertension because of chlorhexidine. I don't know if you're familiar with that, but chlorhexidine eliminates some of the bacteria in our mouth that are really, really necessary to process nitrate. So we don't really have an enzyme in the body to process dietary nitrate into nitric oxide, which is necessary for like cardiovascular function, vasodilation. Sure. So 10% of your nitric oxide in your body comes through processing of these nitrate-reducing bacteria of dietary nitrate in our oral environment. And if you kill those, then you start having cardiac issues, starting with hypertension.
It's just amazing, the oral systemic link, to total health, to total body health, and the oral systemic link, which is still in the world of healthcare, in the world of medicine, it's still downplayed on a daily basis. Like they don't even look in the mouth. Doctors, physicians, they don't even look in the mouth. It could have full ongoing peri-implant or periodontitis, and just of a severe aggressive nature. And they're like writing prescriptions for hypertension, high cholesterol and diabetes, and like just totally ignoring all this still to this day. They could undergo a major cardiac 3-way bypass and not even get referred to a dentist to look at their perio. Yeah. And we're still seeing that. Is it like that in Europe?
Unfortunately, it is. And I think that, I'm a firm believer in the fact that we got to have way better integration of oral health into systemic health, primarily because the key risk factors for oral health are shared with all non-communicable diseases like diabetes, cardiovascular disease, hypertension. It's the same risk factors as for periodontitis. But the challenge is that when you look at family medicine, internal medicine, 90% of what those docs do happens on your blood test. And maybe 10% physical and interview, right? So the challenge is that we don't really have much we can do on a blood test for your periodontitis or anything like that. But I'm very actively working on the research arena to get all the fun stuff we do. People have probably heard about bacterial sequencing or omics technologies and whatnot. We do those things in the lab, but now I'm very excited because there's the first approved diagnostic test in dentistry where it applies these sequencing technologies. We're not culturing the bacteria anymore. They're just running a genetic screening for them, essentially, where they can identify everything that is there, even things we can't culture. And that has become available at your side. So now for some of my patients, the cost, I think, is about $150 per patient. There's a CDT code for that, although insurance coverage is not there yet. So you can charge for it and get reimbursed. And you get a full-on report, as if you had done a blood test, but this is a simple saliva test. And you get your dysbiosis score, you get your gingivitis score, teeth caries score, and a report of what bacteria they have in terms of commensal or pathogenic.
Yeah, I love the idea. Using the science to get better treatment modalities, by far, I'm a big proponent of. I mean, just like somebody who, a physician or a psychiatrist who, before they prescribe a pill, they look at your genetic testing and see if you're susceptible to being to having good positive benefits or side effects of it before you prescribe that. I think that's wonderful.
Exactly.
Leave it to the periodontist. I love it.
That's what I love to say.
To be completely thorough. I'm looking at the topic of international dentistry because that kind of struck the differences between the USA and Europe because it's no secret in the United States, we're just kind of born and bred to think that we're the only people on this planet. I apologize on behalf of all United States of Americans, that we're very much that way. But I mean, I've been all around the world. I was in the Marine Corps when I was 17. I've been to Europe, so I appreciate your other cultures. And I do understand that. But, how is dentistry? Let's just take it to all on four. Let's take it to the audience. How is this different in the United States versus in Europe?
How the full arch work is different. So I will say that here a big driver of things that we do, for instance, FP1 versus FP3 and whatnot, or overdentures, would be cost, right? Because you have a huge lab cost. In Europe, when you look at the cost, lab cost goes so drastically down because the amount of dollars per hour that the technician needs to take is nothing like what the cost of living is here. So services like that are heavily discounted in Europe. So there's way more flexibility, and you see amazing FP1 cases. You see amazing ceramic work, and so the monetary limitation is not as such when it comes to your costs. Of course, patient salaries are lesser there, so you also see some cases of pretty conventional full arch rehabilitation. But I would say that I have seen some amazing clinicians in Europe because the mentality is much more individualized. So whenever you see a patient, it's always a new challenge, always tailored treatment planning. Here, I think we have much better systems in place that make for a great patient experience, make for an amazing workflow in the practice. But sometimes, depending on who the practitioner is, here we might have the process override patient preferences sometime. And that's the reality of it, and I've seen that happen. The downside is that in Europe, the processes are sometimes not as much in place. So you see great variability. You see amazing clinicians where the work that's coming out is top-notch, and you see other cases where the work is just not up to par because processes are not in place. So I will say an amazing clinician in Europe and an amazing clinician in the US, they both deliver outstanding care. But there are individual differences, geographic differences.
Yeah, I appreciate that. I don't want to give us in the United States too much credit. I mean, sometimes a case walks into the consultation room and I'm like, what third world country did you have this done in? And I find out it was done, 3 miles away on Virginia Beach Boulevard. So, we do have to get everybody up to speed, I think. I mean, in the world of academia or those practicing at a high level, like around you, I mean, I know you're affiliated with, Safa and Michael, I know Picos, so I know you're seeing top end work all the time. But sometimes I got to be really careful to say, or, did this come out of, Turkey or Mexico? No, it came out of Virginia Beach, sometimes. So you got to be aware of that. I think that we can all do better. To elevate the profession and teach and get people all up to speed with systems. Yeah. But
I think Adam, I want to add that what you're bringing up, and it's so important, is that the people you just mentioned, and I respect so much, Mike Picos and Safa and yourself. Each and every one of these people in that list is very heavy on being a lifelong learner, right? It's very heavy on continuing education. And you look at, we have to state this. I mean, you look at recommendations or even regulations here, like the ADA recommendation. If you want to place implants and you're a dentist from a code-accredited university, you need 8 CE hours to be able to do that. Now, is that acceptable? Is that something?
You said 80?
8.
8?
8. The last time I checked, that was the recommendation.
I think it should be 800, but
exactly. So I think what sets us apart here in the U.S. is that we have very tight regulations about continuing education. You got to be able to renew your license. You got to get your CE and whatnot. Now, whether this is quality CE and what you need, that's a whole different discussion. But it's very important. So I think I'm learning every day, and I think each and every one of us should.
I think we need to tackle that too, because we do have to get our license. Virginia only requires like 10 or 15 hours every 2 years. It's like ridiculous. I probably sign up for 50 in a year easily, or 100. And so when people come to me and they go, I need to take this class really fast to keep my license, and they're like, I haven't had any CE in 2 years. I'm like, where do you live, under a rock? You can get CE online. You can go on YouTube,
Right.
You can go sign up for it on YouTube. It's so easy to get. But 8 credits to place an implant.
I think so. Don't quote me on that. We got to go back and check, but it's a very, very, very small number.
Yeah. I don't doubt it at all. Unfortunately, it's like we put this, it's like people come out of dental school with this expectation. And I think the public and the boards and everybody, it's like, well, they're a dentist, they can do whatever they want, but they really learn the minimum amount necessary. Right. And I think one thing that I see being a trend is, especially, and I think a lot of generations of dentists do this, but especially the younger generations, is they go, well, I'm going to learn all on 4. So I should take a course.
Right.
A course. A 2-day course. And by the way, they call up and they go, and can I do 3 arches during those 2 days? Or 4, how many arches can I do in those 2 days?
Right.
And they're fresh off the boat out of dental school. And they think once they go to Pecos, they're done. Or once they go to Hogan, they're done. And I think it needs to be said, like, you can't learn this online, and you got to go all around the country. 100%. You got to go see them all. Right. What's full arch training like at Rutgers?
I think at Rutgers specifically, full arch training happens at the graduate level.
Yeah.
We have a really very strong team. We have an outstanding oral surgery team at Rutgers, world-renowned. We also have a very strong perio program with a new program director. And of course, our pros that restores all those cases. There are teams in place and systems in place, but I don't know that we have access to that to the dental students. And at the same time, my mentality is, I'm a specialist, I'm a periodontist, and as a periodontist, I'm a firm believer that general dentists need to be placing implants. It's absolutely necessary to be able to serve the population. But in order to do it right, even if you're a periodontist, a general dentist, a prosthodontist, whatever your specialization is, I think about it from the medical perspective. Would you expect that a person graduating medical school, right, 4 years of medical school, goes to a weekend CE and then can do a hip replacement for you or a knee replacement, right? So why is orthopedic residency, that long? It's about 5 years on average, right? So there's something to be said for that.
Right.
And I think it's amazing, and general dentists should be exposed to implant dentistry. We're integrating that in the curriculum. People become really dental students, they become proficient in what implant dentistry is. They understand everything about the process. They have to do a lot in terms of restoration, right? Because of the similarities between teeth and implants in terms of restoration. But across dental schools in the U.S., there's varying levels of surgical exposure. Mm-hmm. And I'm not yet convinced if the curriculum of the 4 years of dental school is adequate to have the right surgical training. So for me, we have to establish safeguards where people have to do certain things. It doesn't necessarily need to be university-based. There's outstanding C courses, you teach those, you know very well, that people have to go out, but at least a year-long cycle of post-dental degree implantology is necessary in my book.
As a general practitioner, I will agree with you on this, okay? I took a very non-conventional approach, all right? And now, mind you, part of my thinking was, I could go to oral surgery residency. I love surgery, but I didn't, I had a baby, I didn't want to do that many hours, I didn't frankly want to go to a program where I learned how to do, just head and neck dissection and, for cancer patients when I likely was going to come out and just pull third molars and place implants. So I was like, then I could go to perio and place 30 or 70 implants in 3 years. Or this guy behind us in this walls was doing 70 implants a month, Truman. So I took a very non-conventional. I learned from this guy, but I went to courses all over the country. And honestly, in the 2000s, there weren't a lot of classes. I mean, Michael had classes. There was a couple others, but mostly it was Truman knew a guy in Houston or whatever city, USA, and I went and spent a week with him, and just kind of learned. Sometimes they charged me, sometimes they didn't. But that was our education in those days. But I took the time. But the one thing that really helped me was that year in GPR. at Portsmouth Naval Hospital. Very heavily oral surgery based. They didn't even care about the other disciplines, if I'm honest. JB Dental Lab is the lab that full arch clinicians trust when precision truly matters. JB combines advanced digital workflows, photogrammetry compatibility, expert design teams, and high-strength zirconia to deliver prosthetics that fit, function, and last. Their communication is top tier. Their turnaround times are reliable. Their quality is the reason that so many high-volume, all-on-X practices partner with JB Labs. Visit jbdentallab.com for reliable quality, full arch support. And, learning how to, just raise a proper flap, the infraorbital rim and things like that. Learning orthognathic surgery, being exposed to that for a full year. I will agree that as a general dentist, we should come out and do a 1-year residency somewhere in some discipline. And just like medicine. Nobody graduates medical school and goes on and practices as a doctor right away. Do they? Right.
No, you cannot do that.
They go to ER training. They go to this training. I will also say that I believe that in dental school, I think we waste a lot of time on unnecessary curriculum. I mean, do we really have to be taking biochemistry for the 3rd time in the United States? I mean, we've taken it AP chemistry in high school. I took it in college. I took 5 biochemistry classes in college, and now I got to take it again. Do we really have to repeat all of that again, or can we jump into some treatment modalities and some real fine-tune our dental skills right from the get-go? I think we could better use that first year or two.
Yeah, there's a lot of curriculum innovations going on right now. At Rutgers, we have think tanks about this, and we pay a lot of attention in graduating outstanding clinicians. I will say, I wear dual hats, right? I'm a PhD scientist, and I'm also a clinician. I'm also a periodontist. And I truly believe in a strong foundation. You need microbiology, you need immunology, you need biochemistry principles, right? And when it comes to understanding how caries work or how perio works. But we need to do it in a way that it's specific to oral health, because at college, you've covered the broad basis, right? And now you want to know, how does that ultimately link to what I'm doing in a patient's mouth? And the challenge we have as an educator, as a professor, the challenge we're faced with right now is, how can we revamp the curriculum so you can come in and get an intensive 8-week course in immunology, microbiology, and understand how all that you learn in college actually applies now in perio.
So the application of biochem and biochem could be 2 totally separate classes, right? Mm-hmm. But when you came from Greece, but in the United States, to get into dental school, you had to take so many classes of biochem as a prerequisite. So they knew you took it, but then you show up and you're taking it again, the same biochem class. And I would argue every time I took it, it got easier. I think my AP advanced placement high school biochem teacher was harder than they were in college. Yeah. And they were harder than they were in dental school. You know, it was like we had to memorize every molecule of the Krebs cycle in high school. And then in college, we only had to know how much ATP came out. And then in dental school, it was like, everyone knows the Krebs cycle makes ATP, right? So I was like, okay, I'm taking it for the 4th time. I'm just getting dumber. But, that was my experience. Mm-hmm. But I thought, if it's required as a prerequisite, why are we taking it? But now the application of the biochemistry could be completely different. We could jump into like dental specific needs for physical chemistry and biochemistry and organic chemistry. That might be completely different, right? But I felt like we were just repeating, in education in Europe, am I wrong in assuming, or is it a myth that high school, secondary schools will teach more stuff that's typically taught at the college foundational level here in the United States? We have to go to high school and then go to college and be 18 or 22 years old to learn, to even think about going to dental school. I hear that in Asia and Europe, people are learning dentistry like halfway through their secondary education. They're 16 and they're majoring in dentistry, or 18 and majoring in dentistry. Is that true?
Well, I can speak of the system in Greece where I went to high school. And essentially, when you get to your first year of high school, last 3 years, 15, 16, 17 years old, you kind of branch out on either the technical side or the scientific side, tracks, the scientific track, or maybe more of the theoretical literature, classical literature track. So you end up not necessarily majoring, but having kind of an advanced placement into the scientific track where you really focus on biology, chemistry, physics, math, and whatnot. And that's kind of the path that I took. So I would say it's quite an advanced placement scenario, preparing you very well for the university. But the big gap between U.S. and European education, as you know, is what happens after you graduate high school, where in Europe you go straight into dental school. How you get there is a whole different story, but you go straight into dental school.
This is what I've heard. Yeah, go ahead.
Yeah. So in my case, I graduated high school when I was 17 years old. And when I was 18, I was year one DDS.
That's great.
And then graduated 5 years later through a 5-year program. And then I was able to go ahead and practice. Now, it's very intense, very compact. But because you have to finish 4 years of college and 4 years of dental school within that 5-year frame, everything becomes very well pointed towards application.
I like it. Yeah. I wish we had more of a system like that. I think we take our youth in this country and we drag them out in school just for the purpose of being in school almost, to feed the hierarchical system of like, well, the colleges need students, so we're going to force everyone to do that for 4 years. And then we'll let them get a PhD, or then we'll let them get a medical degree or a dental degree or a law degree. And it's like, why can't we just start studying law at 18? Who says that we can't have bright young kids? Why can't we start training them at a younger age? There's some things about education in this country. I'm not sure if you're aware of how it was born and bred out of the Industrial Revolution and just training people to be kind of dogmatic, non-thinker, factory people, just this rote memorization in school where we don't teach people to be creative. We just teach them to recite facts, and they do the same curriculum every year in the United States. I always felt, I knew this at a young age. I remember telling my mom in 4th grade, I'm like, it's February and we haven't done anything new from what we did in 3rd grade yet. Like every year, the only thing that's new is like the last 1/3 of the year. It's just a repeat of the year before. And so I think this country needs to adapt and change its educational program greatly. I really respect the way you do it in Greece. I really very much do.
Well, what might surprise you is that as I was flying, all the way from Newark to here, right? We flew through Pennsylvania, and for example, I can practice up there in New Jersey, I can practice down here in Virginia. If I wanted to practice in Pennsylvania after having my DDS in Greece, my residency here in the US, my PhD, I've been a professor teaching dental students, peri-residents, what you want for over 10 years, I would have to go back and do year 3 and year 4 of the DMZ program if I want to get my license in Pennsylvania. And people will not give me any recognition for the credits that I've gathered or the experience that I have or my licenses elsewhere, right? So the system, I don't think necessarily makes full sense the way we apply right now. And that's kind of an issue, Adam, because as we transition, right, to this revolution in dentistry, because implants are a revolution, full arch, what you do here is a revolution. I heard beautiful stories today of patients who were rambling around about how their life changed and how, their neighbors are seeing it. And this is beautiful. Like, this is what we're here to do. And we can serve patients so much better than we could 20 years ago with new developments and new workflows. As we do that, and the private sector is like scaling up and growing so much, the disparities between academic dentistry and clinical dentistry are huge, right? When you look at an academician, a very skilled assistant professor, salary might be in the range of $150,000 for a person who's a specialist, right? A board-certified specialist, and works 8 to 5 days a week.
Right.
You wouldn't even dream of hiring somebody here for $150,000 a year, or probably wouldn't even dare, because it would be very disrespectful, I would think.
Does anybody want a job? $150,000 a year?
Yeah,
let's do it.
So as this happens, we get more and more international people to teach at the dental schools, right? That maybe cannot practice outside or have other things. Really, academic dentistry is extremely well respected. Outside of the U.S., it's very prestigious.
Right.
In a way, right? Versus here, it's kind of a different ball game. So how are we going to bridge that gap if we don't start making sense into the comparability of degrees and into facilitating these people to really be able to integrate in the system?
Well, the whole, is there another way? Is it possible that there's another way other than just being born and bred here and then spending all your time in high school, college, and then dental school? And I mean, you've got all these degrees, all these accolades. I mean, I ran out of paper trying to print everything that you've done and accomplished in your life, and you can't practice in the state of Pennsylvania, the Commonwealth of Pennsylvania.
I don't want to. I don't want to say anything bad about it. It just happened that I was flying above, and I gave you an example, right?
But it's there's other examples.
Other states, absolutely other states.
No, we're not trying to disparage Pennsylvania. Please, don't send me letters. But but on the same token, first back up. The universities are full of international dentists teaching American students how to do dentistry, yet can't go and practice outside those walls of the institution. That's a tremendous problem.
In the majority of the states,
yeah, that's a big problem. We trust them to train, but they can't go out and practice.
Right. So you see these double standards. Right. And there's a thing in many. So I've been licensed in 4 or 5 states, I think, and practicing all of them, and even more now. So there's a thing in many states called a faculty license, right?
Right.
So we can get a person who graduated, my example, right? I graduated dental school in Greece, cannot practice in the U.S., I do my residency in Perio, and I can be hired by university. Virtually any university in the country will allow this to happen, and get something called a faculty license. Right? Which allows me to teach dental students, specialists, whatever my specialty is, within the specific confines of a university, right, in a state, and supervise any and all procedures that they do, right?
Right.
But I cannot walk across and treat my own patients. So if I treat my own patient, right, and I can't do something well according to state standards, I can harm a patient. Mm-hmm. But if I teach you to go out and treat thousands of patients, I think the harm is way greater, right?
Right, for sure.
So isn't this really a double standard?
Yeah, no, I'm on your side, my friend.
Yeah.
We need a revolution in our education system and our licensure procedure, for what the things we can and can't do. And just, to be able to recognize that there are alternative tracks, like my tract, I mean, I've got, I mentioned this on the last podcast, but, I've got, an institute, and I've had oral surgeons and prosthodontists, periodontists come and say some of the best education they've ever received, and they recognize me as an expert, and I will humbly accept. But if I go to the VA, our Veterans Affairs Department, they won't let me do implant surgery. I can't even place an implant because I didn't go to the higher university. I didn't spend those years, and there's a lot of benefit for those residencies, no doubt. But there can be other tracks of education, is what I'm saying, and other tracks of credentialing. And, can't we all couldn't you just take a paper exam or a test or an oral board?
Well, it
would be that simple.
Yeah, it can't be a free-for-all either, right? There's standards that have to be upheld, and that has to stay very, very transparent and very rigorous. But there's a difference between competency and there's a difference between checklists, right? Yeah, very big one. So I'm very, very competency geared.
Yeah, I believe in that. What can full arch practices and implant dentists, so all of them, general practitioners, periodontists, oral surgeons in the United States, learn from some of the international dentistry that from Europe? And you can speak specifically about Greece. I know you've been in other places in the world, but what could we do better in the United States?
This is such a cool question. It has a lot of depth. I think in Europe people enjoy being a little bit more unconventional. So a lot of things. This might be contentious, but a lot of remote anchorage approaches came from Europe, right? Originally. So a lot of ideas like this, more innovative protocols, being able to take a little bit more risk comes out of there. So what I love is the fusion. I love summits where you were mentioning the one in Greece or, happening over here. I love summits where we put 2 and 2 together. And you see how there might be just fundamentally different philosophies that actually all converged to patient benefit.
Right.
And you can marry the two. And I think the best people that I know that do full arches, they just travel to Europe once a year, easy, and they get more education and they bring people over here. And that mix, that fusion is what makes us really, really excel. And if you look at the protocols that we're doing right now, right, they're fundamentally different than 10 years ago.
Right.
Like who would consider a palatal approach? Who would?
Yeah. I was going to ask you like what? I mean, you just said palatal approach. Yeah. So something that came out of Europe 10 years ago that we're just now talking about now.
Right.
Yeah.
Right. I think so.
It's interesting because, I don't take credit for inventing anything, but I've been hiding implants behind the buccal shelf for years. And a few years ago, I don't know, somebody was like, are you going to teach the palatal approach? And they talked about this palatal approach. I'm like, what is the palatal approach? And I'm like, oh, I've been doing this for a while. Like, there's a name for it. It's being taught.
Yeah.
It just seemed to make sense to me. Like, you can hide it behind all that dense tissue in the palate for lack of anything better. You don't see peri-implantitis start there.
Yeah.
Yeah.
Because of fully keratinized tissue.
Fully keratinized. Oh, yeah. We talked about this earlier. If you have a poorly placed implant and abundant keratinized tissue, do you reckon that it would survive much better than the average implant?
I would say that studies show that you might have even up to a 4x, like 4 times greater risk when you don't have more than 2 millimeters of dense attached keratinized tissue. So possibly. Well,
I think the palatal approach and some of what I've seen in my own practice over the years is evidence to that.
Yeah.
You know, and we were talking about the most common site that I've seen to have to later come in and do a connective tissue graft, regenerative graft around an implant is in the posterior mandible, because you're typically only have 1 millimeter of tissue. And I might place that implant in 12 millimeters of bone with, excuse me, 1 second. Let me silence that phone. We can cut or roll, whatever you want, Evan. I can go at the posterior mandible. We were saying it's one of the most common sites for lack of KG and breakdown and peri-implantitis. And because I could place an implant in 12 or 100 millimeters of bone, but if you have 1 millimeter KG to support that, you often or almost always see bone breakdown. But you contrast that with something in the maxilla where you made a palatal incision and you flapped over, 6, 8, 10 millimeters of KG, and then you ridge split bone. You barely have 3 millimeters, 5 millimeters of bone at the most. I mean, I've ridge split less than 3, and it does fine. Very little bone, much keratinized tissue, much better. You said 4x. You said the literature shows 4x. Yeah, and I think that I've clinically seen that in this practice over 23 years, for sure. Yeah. Great viewpoints. And he's a periodontist when he says the literature shows. I do fully respect it. The difference between, you and me is I can say, I read this once somewhere, and you'll know the name of all 7 authors. I think that's great.
It's fun.
I don't have that kind of a memory. I can barely remember what I had for breakfast, but I know why I do things and they work. Big difference. Well, so what haven't we talked about yet? We should.
I think we covered a lot of things.
Yeah. We should talk about where to find you. You have a peri-implantitis module seminar at the PICOS Institute. Is that right?
I do. Yeah. We just did the V1, the inaugural, a few months back at the PICOS Institute in Palm Harbor, Florida, and we're going to be holding the next one in the fall of 2027.
A full year away.
Yeah,
not this fall,
full year away.
Next year. I'm sure we'll find you speaking before then. Do you know where? You'll be back at PICO Symposium maybe? Or
I will be back at the PICO Symposium and a couple of other main podia in the country. I'll be at the American Academy of Period meeting, and a lot of things coming up. It's all on my website, drkotsakis.com. If you can spell my name correctly, you get access to a lot of cool things there, protocols and literature and articles, so just stay tuned.
I know for a fact that if you're trying to spell Kotsakis correctly, if you punch it into Google, it'll say, did you mean Kotsakis? And you'll just say yes. So don't worry about the spelling. Google knows who you are, my friend.
Good.
Yeah, Google knows who you are. Do you ever do like live training or surgical training? Are you going with PICOS to Brazil or anything like that? Or
no, I do not. I do live surgery at my course at PICOS, and then I do one-on-one mentorship. So
yeah,
that's how it usually works.
So a couple of questions before you go. I think we're about in an hour. So you saw full implant choice for a short bit. You flew in, you've been here for a few hours. How can I do better?
Wow, that's such a tough question. I honestly was impressed by, the time you invest into patients, the heart connection you have with all the patients, the way they spoke to you, and it's just remarkable. It shows respect, builds safety. I think very patient-centric practice. So honestly, for me, that's the compass right? Once you're able to build safety with patients and they trust in what you do and you do great quality work, that's the foundation. So honestly, I don't have anything to say right now. Well, maybe the only thing that I would say is use more shoe shine in peri-implantitis. That's my advice to you.
He was not impressed with my laser. I was so happy to show him my laser. He went, nice. You have some cotton? Now I understand the look on his face. Yeah, he was not impressed at all. $65,000 mistake. Better than we had in 10, 12, 14, whatever it was.
That was the best. And still to this day, I don't want to send the wrong message. It's great. It's just not worth investing only for peri-implantitis at this point.
I'm going to be honest with you. I'm going to have a little bit of trouble pulling it, like shoe shine in my implant. I think I might still pull out my laser. I mean, I don't know.
You should.
Just to be honest with you. I got one final question, because you were on Michael Picos's podcast lately. Who's better? I mean, you got to, which one?
Yeah. You guys are amazing, and thank you really for having me here. Truly appreciate it and had fun.
I'll answer that.
Had fun doing it.
Michael, I'll give it to you. You are the current living godfather of implant dentistry.
Absolutely.
We've had a lot of godfathers in implant dentistry. I think Michael probably in the United States, probably in Greece as well, since he is Greek, where they invented Windex. If you've seen the movie, My Big Fat Greek Wedding.
Yeah.
You watched it?
Yeah.
The father who said everything in the world came from Greece. I will give it to Michael Picos. You're probably better than me for a short time until you retire, and then I'm going to come after the title. But hey, it's been an honor having you on here. I got something for you, by the way. The All-In, All-On-X Pod Challenge coin right there. You earn my respect, my friend.
Thank you so much, Adam.
Thank you.
Wonderful to be here.
All right, I'm Dr. Adam Hogan, All-In, All-On-X Pod. Thank you for listening. If you've enjoyed what you've heard here, please hit subscribe wherever you're listening, on YouTube, on the Pod app, on Spotify. Please subscribe on all three. Send me your comments. Send me things you enjoyed, things you dislike. We can take it from there, make this better for everybody. But until next time, remember, you've got to go all in if you're going all on X. This is not easy procedure to do. So buckle up and get all in. Yeah.
All right.
Thanks, brother. All right, let's go see a couple patients. All right, you too. Hey, if today's conversation resonated with you and you're looking to sharpen not just your technique, but your judgment, your discipline, and your long-term vision, then this is exactly why we built the Atlantic Implant Institute. This is not just some collection of disconnected modules. This is the core continuum for education and full arch workflow. It begins with Module 1, Core Bootcamp Fundamentals, where we establish surgical foundations, diagnostic discipline, and repeatable decision-making under real-world pressure. And then it continues with Module 2, Advanced Prosthetics and Full Digital Workflow, where occlusion, vertical dimension, aesthetics, condyles, and execution all converge. And then we have Module 3, which tackles remote anchorage, pterygoids, zygomatics, complex anatomy, taught through biomechanics, planning for predictable outcomes. And after the continuum, we have modules in FP1, fixed immediate load, and also business, how to 5, 10, 20. This is business, leadership, and operational strategy so that you can build surgically what actually works in practical business. If you're ready to go into full arch dentistry with intention, structure, accountability, and purpose, you can learn more at theatlanticImplantInstitute.com.